I have no conflicts of interest to disclose. So this is the outline of my talk today. I'll initially be talking a little bit about the background, then I'll delve into the cytokine and vaccine trials in the adjuvant setting. Talk a little bit more in detail about the various trials which evaluated tyrosine kinase inhibitors, again in the adjuvant setting, and move on to the ongoing immunotherapeutic trials. Again, as Dr. Fan mentioned, this is staging of kidney cancer. Stage 1 is when the tumor is limited to the kidney itself. It's less than 7 centimeters in size. Stage 2 is when the tumor is up to 10 centimeters in size, but again, limited to the kidney. Stage 3 is when the tumor involves the vasculature, and also there's no involvement of the lateral adrenal gland, but in stage 4 disease, the tumor now penetrates the gyrotous fascia, and also there could be distant metastatic disease. So surgical resection is the standard of care for patients with localized or locally advanced RCC with either a radical nephrectomy or nephron sparing surgery. A radical nephrectomy includes resection of the kidney, perinephric fat, regional lymph nodes, and the ipsilateral adrenal gland. It is a preferred option of therapy if the tumor extends into the inferior vena cava. For most patients with localized RCC, there's no role for adjuvant therapy after complete resection of the primary tumor. However, an exception is for patients who have stage 3 disease, who have clear cell histology, and who have a high risk of relapse. High risk kidney cancer is associated with a 40% risk of recurrence. The intent of adjuvant therapy is to eradicate micrometastatic disease after curative resection with the goal of preventing or delaying recurrence and improving overall survival. Identifying patients with high risk of recurrence. The 5-year survival rate for patients who present with stage 3 disease is 67%, and the 5-year distance recurrence rate in patients with locally advanced disease is 64%. So an important aspect of adjuvant therapy is to select patients who are at increased risk of recurrence, who benefit from adjuvant therapy, and also to spare low-risk patients from adverse effects of adjuvant therapy. There are several clinical risk prediction models which have been developed to assess the risk of recurrence in patients with localized RCC. The table here summarizes the clinical risk predictive models in localized RCC. The University of California, Los Angeles Integrated Staging System, or the UISS, incorporates TNM classification, Fuhrman grade, and ECOG performance status to estimate the postoperative 1 to 5 year overall survival. For patients with localized RCC, the 5-year survival rates were 92%, 67%, and 44% for low, intermediate, and high-risk groups, respectively. The Memorial Sloan Kettering postoperative nomogram incorporates several prognostic factors, including pathologic stage, Fuhrman grade, tumor size, necrosis, vascular invasion, and clinical presentation to predict the 5-year probability of freedom from recurrence in patients with clear cell RCC who have undergone a nephrectomy. The size, stage, grade, and necrosis score again used the TNM classification, tumor size, nuclear grade, tumor necrosis to predict cancer-specific survival. After a mean follow-up of 10 years, the estimated cancer-specific survival rates at 1, 3, 5, 7, and 10 years were 86%, 74%, 68%, 63%, and 60% respectively. The TNM stage, tumor size greater than 5 centimeters, higher nuclear grade, and histologic tumor necrosis were associated with a greater risk of death from clear cell renal cancer. Finally, the Leibowitz score comprises stage, tumor size, regional lymph node status, and histologic tumor necrosis, and has shown to predict metastasis-free survival after radical nephrectomy for patients with clear cell RCC. The estimated metastasis-free survival rates were 87% at 1 year, 78% at 3 years, 74% at 5 years, 71% at 7 years, and 67% at 10 years. Multivariate analysis was performed and it showed that the tumor stage, regional lymph node status, tumor size, nuclear grade, and histologic tumor necrosis were associated with progression to metastasis. Gene expression in localized RCC. Several genomic signatures have been proposed that incorporate individual tumor biology into risk stratification. Currently, however, none of these genomic signatures are used in clinical practice. With further prospective validation, these genomic signatures may be used to identify high-risk patients for inclusion in future clinical trials. The Oncotype is an RNA-based gene expression recurrence score based on an assay of 16 genes involved in vascular processes, cell growth and division, immune response, and inflammation, and it was developed from nearly 1,000 patients with localized RCC who underwent a nephrectomy. In an external validation cohort of more than 600 patients, the continuous recurrence score was associated with a significantly recurrent-free interval. The recurrence score was also predictive of 5-year overall survival and renal cancer-specific survival in patients with localized RCC. Moving on, Brook and colleagues developed the ClearCode 34, which is an RNA-based 34-gene expression panel from 72 samples of localized RCC to identify good risk or CCA and poor risk or CCB kidney tumors. The predictive accuracy of ClearCode 34 was tested in a set of 380 patients with non-metastatic RCC from the TCGA database and showed that the CCB tumors were associated with an increased risk of tumor recurrence. Hazard ratio was 2.3 and an increased risk of death from renal cancer. Hazard ratio was 2.9 compared with CCA tumors. This model was also validated in an external cohort that included 157 formalin-fixed clinical samples from non-metastatic RCC. The ClearCode 34 score outperformed previously described UISS and S-sign scores to predict cancer-specific survival and risk of recurrence. Finally, Morgan and colleagues developed an RNA-based cell cycle progression score based on 31 genes involved in cellular proliferation and compared it to the Karowitz nomogram to develop a composite RCCP score. The RCCP score was identified as an independent predictor of recurrence and disease-specific mortality after adjusting for clinical variables, including the baseline nomogram. With a concordance index of 0.87, the RCCP score stratified patients into low risk and high risk categories with 99% and 84% cancer-specific survival probabilities, respectively. Early loss of function of the 1-hippoLindauer VHL gene during tumorigenesis of clear cell RCC causes accumulation of hypoxia-inducible factor, which again results in excessive production of pro-angiogenic factors such as VEGF, fibroblast growth factor, and platelet-derived growth factor. Oral multi-targeted TKIs such as sunitinib, pazopanib, sorafenib, and axitinib oppose this pro-angiogenic environment and induce tumor cell death by inhibiting downstream signaling of VEGF as well as other tyrosine kinases. Similarly, cabozantinib and lenvatinib target the VEGF receptors in addition to kinases implicated in resistance such as MET, AXL, and FGFR. Constitutive activation of the mTOR signaling pathway also plays an important role in tumorigenesis and growth of many malignancies, including RCC. Checkpoint inhibitors have demonstrated clinical activity against a host of malignancies and constitute the latest therapeutic development in the field of metastatic RCC. Under physiologic conditions, the PD-1, PD-L1, and CTLA-4 checkpoints attenuate T-cell activation and are critical to maintain the balance between self-defense and self-tolerance. This balance can be dysregulated by tumor expression of checkpoint proteins such as PD-L1 that promote tumor tolerance of cancer cells. Blocking the PD-1, PD-L1, and CTLA-4 axis invigorate exhausted T cells to foster anti-tumor immunity. Now, moving on to cytokine and vaccine trials in RCC. Cytokines, including interleukin-2 and interferon alpha, were the earliest immunotherapeutic approaches for the treatment of metastatic RCC. Here's a table that summarizes the various trials evaluating cytokines and vaccines in the adjuvant setting. On the basis of the activity of high-dose interleukin-2 and other cytokines in metastatic RCC, the cytokine working group randomized 69 patients with locally advanced RCC of any histology to either high-dose interleukin-2 or observation. There was no difference in the 2-year disease-free survival in the observed arm versus the treatment arm. In the intergroup trial, 283 patients were randomized to either interferon alpha or observation. After a median follow-up of 10.4 years, the median survival was 7.4 years in the observation arm and 5.1 years in the treatment arm. There was no improvement in the 5-year disease-free survival or overall survival in either the treatment or the observation arm. In another study, 310 patients with RCC of any histology after a partial or radical nephrectomy were randomized to low-dose interleukin-2 and interferon alpha versus observation alone for 5 years. At a median follow-up of 52 months, there was no difference in recurrence-free survival or overall survival between the two arms. Moving on to vaccine trials in the adjuvant setting, the autologous tumor-derived heat shock protein peptide complex, or HSPPC96, was evaluated in the adjuvant treatment of RCC. Wood and colleagues randomized 818 patients to receive HSPPC96 versus observation. At a median follow-up of 2 years, there was no difference in recurrence-free survival in the tumor vaccine arm versus the observation arm. Finally, a German phase 3 trial evaluated the role of adjuvant autologous tumor vaccine in 558 patients with RCC who had undergone a nephrectomy. The primary endpoint of the trial was to reduce the risk of tumor progression. The 5-year progression-free survival rate was 77.4% in the vaccine arm versus 67.8% in the observation arm. There were various concerns regarding this study. There was a concern that some recurrences were missed because some patients had only physical examinations at follow-up visits, which could have easily missed early recurrences. And also, the median tumor size in the observation arm was 0.5 centimeters larger than that in the vaccine arm. Moving on to adjuvant tyrosine kinase inhibitor trials in RCC. Given the significant anti-tumor activity of VEGF-R TKIs in the metastatic setting, several tyrosine kinase inhibitors were evaluated in the adjuvant setting. The ASSURE or adjuvant sunitinib or sorafenib versus placebo in resected unfavorable renal cell cancer trial randomized 1,943 patients with an increased risk of recurrence in 1:1:1 fashion to receive sunitinib 50 milligrams daily for 4 weeks on and 2 weeks off, or oral sorafenib 400 milligrams twice daily continuously, or placebo for 1 year. It included approximately 21% patients with non-clear cell histology, excuse me, and 9% of patients had stage 1 disease. Excuse me. The primary endpoint was disease-free survival according to investigator review. Because of the high discontinuation rate secondary to adverse effects, the starting dose of sunitinib was reduced to 37.5 milligrams daily for 4 weeks on and 2 weeks off, and the starting dose of sorafenib was reduced to 400 milligrams daily. The primary analysis showed no differences in disease-free survival in the treatment arms compared with the placebo arm. The median disease-free survival was 5.8 years in the sunitinib arm, 6.1 years in the sorafenib arm, and 6.6 years in the placebo arm. Grade 3 or worse adverse effects included hypertension, rash, fatigue, hand-foot syndrome, and were observed in 63% of patients in the sunitinib arm, 72% of patients in the sorafenib group, and 25% of patients in the placebo group. The STRAC trial randomized 615 patients with high-risk RCC in a 1:1 fashion to receive either sunitinib 50 milligrams daily or placebo on a 4 weeks on, 2 weeks off schedule for 1 year. Dose interruption or dose reduction to 37.5 milligrams daily was allowed while maintaining the 4 weeks on, 2 weeks off schedule. The primary endpoint was disease-free survival according to blinded independent central review. Secondary endpoints were investigator-assessed, disease-free survival, overall survival, and safety. Median duration of follow-up was 5.4 years. The STRAC trial met its primary endpoint of improvement in disease-free survival with sunitinib compared with placebo. The median duration of disease-free survival was 6.8 years in the sunitinib group and 5.6 years in the placebo group. Hazard ratio was 0.76 and the p-value was significant at 0.03. However, the difference in disease-free survival between the sunitinib group and the placebo group was not significant based on investigator review. Disease-free survival in the higher risk group, that is patients who had a T3 tumors or lymph node involvement, Fermin grade greater than 2, and T4 disease, was longer in the sunitinib group compared to the placebo group per central review. But again, this was not significant when it was done by the investigator review. A recently updated analysis showed no improvement in overall survival in the sunitinib group compared with the placebo group. The most common adverse events in the sunitinib group were diarrhea, hand-foot syndrome, hypertension, fatigue, and nausea. Up to 65% of patients in the sunitinib group experienced greater than grade 3 adverse events compared to 23.3% of patients in the placebo group. Because of treatment-related adverse effects, 28% of patients who received sunitinib discontinued the treatment compared with 5.6% of patients in the placebo arm. Due to the improvement in disease-free survival, the US Food and Drug Administration approved sunitinib as adjuvant therapy for high-risk RCC in November 2017. The PROTECT trial randomized 1,538 patients with high-risk RCC, including N1 disease, to pazopanib 800 milligrams daily or placebo for 1 year. The initial trial design instituted a starting dose of 800 milligrams of pazopanib for 1 year. However, after an unexpectedly high rate of dose reductions because of drug-related adverse effects, the starting dose of pazopanib was reduced to 600 milligrams daily. The primary endpoint was changed to disease-free survival in an intention to treat 600 milligrams group versus placebo, and the secondary endpoints were changed to disease-free survival in an intention to treat 800 milligram cohort and in all randomized patients. The primary analysis showed no improvement in disease-free survival in the intention to treat 600 milligram group compared with placebo. Pazopanib did not demonstrate an improvement in overall survival in any of the cohorts. Because of adverse events, 51% of patients in the 600 milligram group and 60% of patients in the 800 milligram group required dose reduction. Most common adverse events leading to pazopanib discontinuation was an elevation in ALT. The ATLAS trial was a phase 3 trial that randomized 724 patients with high-risk disease to either receive axitinib 5 milligrams twice daily or placebo. The primary endpoint was disease-free survival according to an independent review committee assessment. The secondary endpoints were overall survival and safety. The ATLAS trial was terminated early at the time of pre-planned interim analysis because there was no significant difference in disease-free survival with axitinib compared with placebo in the intention to treat population. The treatment-related adverse effects occurred in 91% of patients in the axitinib arm and 56% of those in the placebo arm. The most common adverse effects related to axitinib were hypertension, proteinuria, and hand-foot syndrome. Although trials evaluating tyrosine kinase inhibitors appear to be similar, there are some important differences in patient selection and drug exposure, which may explain their conflicting results. The ASSURE trial was a cooperative group study that occurred patients in the United States and Canada, whereas PROTECT, STRAC, and ATLAS trials were industry-sponsored phase 3 studies that occurred patients internationally. In terms of patient selection, the ASSURE, PROTECT, and ATLAS trials included patients with low-risk disease, whereas the STRAC trial only enrolled patients with high-risk disease. In terms of drug exposure, in the ASSURE trial, 69.6% of patients received an initial full starting dose of sunitinib, whereas in the STRAC trial, 100% of patients received the full intended starting dose of sunitinib. In the PROTECT trial, only 26% of patients received an initial starting dose of 800 milligrams daily, and this was changed mid-study to 600 milligrams daily because of concern about toxicities. Moving on to immunotherapy at the adjuvant setting. Immune checkpoint inhibitors targeting the PD-1, PD-L1, and CTLA-4 pathways demonstrated significant anti-tumor activity in patients with metastatic RCC. The ability of immune checkpoint inhibitors to maintain anti-tumor efficacy even after their discontinuation generated interest in evaluating immune checkpoint inhibitors in the adjuvant setting. Currently, 5 trials are underway to evaluate the role of immune checkpoint inhibitors in the adjuvant setting for high-risk RCC. The IMMOTION 010 trial is a phase 3 multi-center randomized placebo-controlled double-blind study of atezolizumab as adjuvant therapy for 1 year in patients with clear cell RCC at high risk of developing metastasis following nephrectomy. It includes patients with T2 to T4 disease with or without sarcomatoid differentiation or lymph node involvement. The primary endpoint is disease-free survival. This trial is currently active and is recruiting patients. PROSPER is a phase 3 randomized trial comparing perioperative nivolumab versus observation in patients with RCC undergoing nephrectomy. Patients will receive 2 doses prior to surgery and adjuvant nivolumab for 9 months. Primary endpoint is again disease-free survival. The Keynote 564 study is a phase 3 randomized double-blind trial of pembrolizumab in the adjuvant setting. Duration of treatment is for a year, and the primary endpoint here is disease-free survival. The CheckMate 914 trial is a phase 3 randomized double-blind study of nivolumab monotherapy or nivolumab combined with ipilimumab versus placebo in patients with localized RCC who underwent either a radical or a partial nephrectomy and who are at high risk of relapse. Duration of treatment is 6 years, and the primary endpoint is disease-free survival. Finally, we have the UCSF phase 2 study of perioperative pembrolizumab-based combination therapy in patients with locally advanced or metastatic RCC prior to cytoreductive nephrectomy or metastectomy. It includes patients with clear cell RCC and consists of 2 cohorts. Patients will receive 3 doses of therapy prior to nephrectomy, and patients with an R0 or R1 resection will receive a year of therapy, and patients with an R2 resection will receive treatment for 2 years. Patients in cohort A will receive pembrolizumab monotherapy, and patients in cohort B will receive a combination of pembrolizumab and axitinib. The primary endpoint evaluated here is a proportion of patients with a greater than 2-fold increase in the number of tumor-infiltrating lymphocytes between pre- and post-treatment specimens assessed by IHC. In conclusion, the intent of adjuvant therapy is to eradicate micrometastatic residual disease after curative resection, with the goal of preventing or delaying recurrence and improving overall survival. The merit of using disease-free survival as a surrogate marker for overall survival in adjuvant trials is debatable, potentially making it difficult to recommend adjuvant therapy with significant adverse effects to patients. A meta-analysis by Hirschman and colleagues evaluating disease-free survival as an early surrogate marker for overall survival in adjuvant trials for RCC found a modest correlation between the 5-year disease-free survival and overall survival. In high-risk localized RCC, adjuvant trials conducted over the last 2 decades with a variety of systemic therapies failed to show an improvement in overall survival. Vascular endothelial growth factor TKIs were extensively evaluated in the adjuvant setting. with somewhat conflicting results. Only one trial, the S-TRACK trial, showed an improvement in disease-free survival, but no improvement in overall survival. The issue of inadequate drug exposure may explain why VEGF TKIs do not show a significant improvement in disease-free survival consistently across trials, and it was noted that even at optimal exposure, the clinical benefit was modest at best. From a biologic perspective, there are several theories that could explain the limited efficacy of VEGFR TKIs in the adjuvant setting. One explanation is that micrometastases in the adjuvant setting do not require the support of tumor angiogenesis. Therefore, a VEGFR TKI would not eradicate micrometastases. Another theory is that VEGFR TKIs are cytostatic rather than cytotoxic and thereby enable micrometastasis adaptation. The limited benefit of VEGFR TKIs in the adjuvant setting emphasizes the importance of a better understanding of the mechanisms of recurrence, identifying high-risk patients based on tumor biology, and enrollment of high-risk patients in clinical trials. Thank you.